Welcome
Hello.
everybody to our webinar today. I'd like to begin by acknowledging the traditional owners and custodians of the land and waterways from which we are all zooming in today. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations and will work together on closing the gap. My name's Helene and working alongside me in the background is Jade. We are the Workforce Development Officers at Westfield PHN. I'd like to welcome everyone to our webinar, Intellectual Disability. Just a little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. Jade has that link up there at the moment. I have an upcoming events on the screen, but the major one we would like to highlight is our annual Primary Care Refresher Conference. The program has been uploaded in that handout section. I would like to just let participants know that they will be on mute for the course of this webinar, and should you have any questions, just pop them in the chat box, in the questions box, and I will ask them on your behalf in question and answer time. They will all be answered anonymously. So at this stage, I will hand straight over to Professor Nick Lennox, who will run the webinar. Thanks, Nick.
Thank you, and welcome everybody. Thank you to this webinar, which is a fresh look at intellectual disability. And today we've got a group of 4 presenters, including myself, to talk to you about intellectual disability and healthcare as relevant to the primary healthcare area. And this is part of the Supporting People with Intellectual Disability to Access Health or SPIDER project. Move on to the next slide. So I'd also like to acknowledge people with a lived experience of an intellectual disability, and acknowledge their supporters and families and carers and disability services and advocates, and acknowledge as part of that it's massively contributed to the work and the progression we've had in this field. And I think people that worked in this field like Rhys and Andrew and Robert would agree with that entirely. So acknowledging the people with lived experience. So as I said, I'm Nick Lennox. I'm formerly a GP and have been a head of the University Centre for about 30 years, working on health and intellectual disability, originally at the University of Melbourne and formerly at the University of Queensland. And currently I'm working as a senior medical advisor to health and disability section of the primary care division of the Department of Health. And I'll talk something a bit more about their work. With us today is Rhys Adams, who's the head of the Centre for Developmental Disability Health, you can see on your screen. And I'll introduce him after I've talked. Then Andrew Pridding, who's a nurse practitioner working at the very important Victorian Dual Disability Service, which is addressing the needs of people with intellectual disability and mental health problems. And finally, Robert Ward, who's a GP and actually has got a lived experience of delivering primary care, and to give the kind of primary care perspective on what the situation, and give the real hands-on perspective, I think, of what we need to do and what we need to focus at and what are the new things in this area. And finally, at the end of those presentations, we will, at about 1:15, we will move to questions and answers. And as has already been said, we'll feed those questions to the various presenters. So what I might do is now move on to my bit of the presentation. And what I'm going to do is not actually use PowerPoint slides, because, anyway, that's what I've decided to do. It's something I know very well. So the definition of intellectual disability, when I think about this area, is what's important in primary care is the key things. But if you look at the standard definition of intellectual disability, it's all about IQ score, about adaptive function, and onset before the age of 18. Usually the first 5 or 6 years are considered the developmental period, the person's got a developmental delay, rather than labelling it as an intellectual disability, but that varies a little bit. So what does that actually mean in practice? If you're in practice, and I did this for a long time, you think that you can make this diagnosis on the run, and I've been wrong. But there's often people where it seems relatively apparent, and it's worth questioning yourself as to whether you think it's really has affected their cognitive function, or that it's actually affected the way they interact as a social being or communicate. And so sometimes you can actually get this wrong, but sometimes it's pretty obvious, and other times it's not obvious at all. And if you look at the definition, we're talking about, theoretically, it's 2 standard deviations from the norm, which is 2.3%, if you remember your normal curve of the population. It's called the Z part of the curve. And the biggest part is, of course, around the 70 IQ point. Around that point, when you test it, there's a huge amount of variation of 7 IQ points. So people move in and out of definition, actually, according to their adaptive skills as well. So there's a very big grey zone. And I think what this speaks to as a practitioner is that you and I as practitioners will talk to people and get some sense that they may have a difficulty understanding what's going on. And there is quite a much larger population who do have major health literacy and communication issues. So being aware of that and thinking about, well, have they got a true cognitive impairment can be quite important. Indeed, I have to tell you, in childhood, sometimes they can't use high quality standard tools because it's just not possible to deliver those in this context. So sometimes the diagnosis in childhood is, it has got a certain amount of uncertainty around it. And in fact, the international literature says the diagnosis can often be picked up later in the school life, when the children are being pushed very hard to perform around the age of 15 or 16. So that's enough about definition, but be cautious. There is a whole lot of people with health literacy and communication issues that merge into this group. This population have stark health disparities, is the truth. The median age of death is 54 years, and that is 27 years younger than the general population. There is 38% of all deaths are potentially avoidable in this population, and that's double the proportion of potentially avoidable deaths as compared to the general population. So that is quite substantial. But you know what that means is there's a lot we can do, actually. There's a lot of effective things in the primary care space that you can do, being vigilant and thinking about things, and we'll talk about those things more. If you look at people with intellectual disabilities, they have multi-morbidities. There was a big Australian study which found 5.4 conditions, half of which were not picked up at all, or if picked up, very poorly managed. So it means that thinking through what's going on here in terms of raw health conditions that we're ignoring is really important for everybody working in this space. It's also well known that this population do not get health promotion, health prevention, much less than the rest of the population. And it's one of the big prompts and the big reasons for annual health assessments, which I'll mention a little bit later. So in addition to all that, we know that there's measures of fragility, and there is an early onset of fragility in this population. So in summary, we've got a at-risk population where there is things that you can do as a primary care provider that can really, really make a difference. And in my simplistic mind, it's actually doing the things that you do every day, but doing them well and thinking around the corners, what am I missing here because I'm not getting the usual communication? I'm making some assumptions. And examining your practice in that context can be a really powerful tool to getting this right and delivering really good quality care. So in recognition of this, the federal government has, for the first time, put significant dollars into improving the health of people with intellectual disability. And there's a national roadmap to improve the health services of people with intellectual disability, which has been released and not that long ago, in fact. And what I'll ask them to do is put up a link to that roadmap if you want to see the details, because it's a detailed program of work for the next 10 years. So there has been a significant commitment, and it does things like improve the supports for people with intellectual disability and their families and carers. It looks at developing better models of healthcare better use of the current MBS items, improving continuity of care, because continuity of care is a very powerful vehicle for high quality care, and better coordination of care, because anybody that works in this realises that the coordination and integration can be a problem in the healthcare system and difficult to achieve, even though your best efforts. So better coordination and better support to healthcare professionals like yourself to provide better care, because as much as particularly you could sit there and think, oh, this is easy. It isn't easy. It's actually complex. It actually is rocket science to deliver good care. It is really hard to deliver good care, and people shouldn't forget this. And practitioners need to be in a position where they can deliver the most optimal care they can. And virtually everybody, care practitioner I've come across, has got the skills to do this. So in terms of budgetary announcements, the government has put in the 2021 budget 6.6 million over 4 years to support programs like this current programs you're involved in for the Precept program. It also in the last budget put 12.7 million to support annual health assessments, 6.7 for the annual health assessment, 12.7 million overall, 1.4 million to scope and design a national centre of excellence, and 4.6 million into developing the health curriculum and improving the training of health practitioners across Australia. Recently in the last couple of weeks, there's also been an announcement of the funding for establishing a centre of excellence, $8 million, and for 20 million towards research to improve the health outcomes of people with intellectual disability. So the good thing about this is there's actually significant support at a federal level to try to help you do your job better. And I welcome you to examine your practice and think about how you can do this practice as a consequence of this webinar. Now, that's enough of me. I think we'll move on, and we've invited Rhys Adams along, who will give you the lens from the allied health care support for people with intellectual disability, and look at the kind of holistic. And Rhys is actually the head of the Centre for Developmental Disability Health Victoria, which was at the forefront of improving healthcare, first established actually in 1992. So welcome, Rhys. Thank you.
Thanks, Nick. Appreciate it. And hello to everyone. I guess, yeah, as Nick has said, I'm from the Centre for Developmental Disability Health, and the centre has existed long before my tenure as head of the centre. And Nick has also been a huge contributor to the centre's work and a great ally and partner of our work. I also apologise in advance that my dog just snuck in through the gap in the door, and she's a bit of a snorer, so apologies well in advance on this, working from home. So to give you a bit of a background on the Centre for Developmental Disability Health, or the CDDH we refer to it as, or just the centre, we're a Victorian Department of Health funded program to support adults with intellectual and developmental disabilities. So we typically now take 16 years and older, and that's because we've actually seen in more recent times very much a valuing of the transition age group, where we want to successfully help transition people from their paediatric services into the adult systems, which is really important to note, and particularly when we start to talk about holistic care. Our centre provides clinical services, so we're a secondary consult service. We have a medical team and we have a nursing team that provide support and advice to primary care physicians as well, and not just GPs, but also allied health and specialists. We provide the support particularly around more comprehensive assessments for patients, and we try to work always in partnership with those primary care physicians. However, obviously at times, sometimes people don't necessarily have a GP, and so we sometimes pick up people, we do assessments, and then we reach out and try and find GPs in people's local areas. So as you can imagine, as a statewide health service, particularly in a regional aspect, it's sometimes quite challenging to link people into primary care. We also provide education, and a lot of that is to undergraduate medical students through Monash University, but we also have education relationships with Melbourne University. We also work in research and innovation. That I guess as a holistic point of view, as a service, we're very lucky enough to have all the tools to provide an evidence-based practice, so to speak. And we continue to work on that and work again with our partners broadly. I should probably also mention that the centre is based at Monash Health here in the southeast, so we're Victoria's largest tertiary health system. Prior to that, we were at Monash University until 2015, and since moving to Monash Health, we've seen a huge opportunity and learning around the difference between the tertiary systems and the primary systems and how they interface, not just disability and health, but equally how our state and federally funded jurisdictions can challenge how we support people with intellectual disability receive their healthcare. We provide our clinical care via a hybrid telehealth and face-to-face care model. Now, this model has been introduced since COVID particularly. Obviously, like many other health practitioners, we too moved to telehealth to try and protect both our patients but also our workforce. We saw huge success from that, and we see a longevity to telehealth, particularly for those people that find it quite anxiety-provoking to come into a clinical setting. So I encourage people to use telehealth where they can and where appropriately, but also completely we recognise that it does not remove the need for a face-to-face for physical assessment. As Nick mentioned, we do use a holistic model of assessment, which I'll explain in the next slide. But before we do move on to the next slide, I also thought I'd do a quick little plug. We, at the end of this month, our centre is about to launch the My Lived ID Hub, which is a Commonwealth-funded online digital platform for people with intellectual disability and mental health or mental well-being, as we're preferring to call it. And so we look forward to launching that. And it's a resource for both people with lived experience with intellectual disability, their supports and families, and also health professionals. It does have a learning management system, so we hope to see education continue to grow through this platform, and the Commonwealth has kindly invested 4 years additional funding into its development. So it's been a fantastic opportunity, and we look forward to launching at the end of this month. Next slide, please. So why is holistic assessment so important? Well, mostly it embraces the intersectional influence on health. Now, there are different models out there that people may or may not be familiar with, like the World Health Organization's International Classification of Function, Health and Disability Framework, and say that 10 times fast. But it's got significant elements that look at body structure and function, environment, function, resources and context, and there's 6 main elements. So I can't remember off the top of my head because I didn't put the visual on the slide. But it is a great framework to apologies for the dog going off. It is a great framework for understanding the intersection between key elements that can influence the health of people with disabilities. But also, I'm an occupational therapist by training, and within our practice, we have many different models of practice, like other health professionals. And for us, we have models such as my personal favourite, the person, environment and occupation model, where we look at the person, which includes their health, their environment, so including their supports, and of course their occupation, so the activities that they participate in. I think our slides have just gone a little bit awry. With having holistic assessment, and I'm just apologies about that. I think she's spooked by ghosts. The whole point of holistic assessment is it provides us the opportunity for interprofessional support. So by providing holistic, do you want me to pause while we get the slides fixed up? Maybe. I will close the door on that note while that slide is being fixed up. Oh, are we going okay there with the slides?
There we go.
There we go. So it does allow for then the opportunity to start picking up things where people might need, for example, from an allied health perspective, communication assessments, physiotherapy, or even exercise physiology for around movement and exercise for people to maintain good health. So holistic assessments are really good for picking up other professionals' needs, and so we can start to do comprehensive care plans. It does require good coordinated care. That is the challenge that comes with this, and obviously from an adult health systems, we're very much challenged to meet this need, and it's often because we've structured our system in such a way that we work in silos. So we do need to have someone play the role as coordinator, and often the expectation from a health perspective does fall on GPs, and I do not see that necessarily as the role of GPs, but I do see it as the GPs play a very, very, very important role in being the awareness of all these professionals that are assisting this person to achieve their best quality of life. Next slide, please. So where I come into allied health to talk about this with our general practitioner friends, we know that without good function, you're unlikely to have good health, and that's why it goes vice versa. And so allied health plays a really great role in what they're doing with their general work around assessments of daily function or other needs, where they can start to pick up if someone has deteriorated. And sometimes this can be the smallest thing. And I use an example of such as people with Down syndrome. We know that there is a high prevalence of Alzheimer's dementia in Down syndrome. And so sometimes people don't pick up, their supports don't necessarily pick up that their change in their regular activity or maybe their regular speech might go. And so what they do is they compensate because they are supports and often do what they think they have to do and don't necessarily take the person to be assessed to look at preventative actions. And so often what we can see with this cohort that when they do deteriorate, it's often coming a little bit later where we can't necessarily put in the assessments that can, the interventions that can help support the person stay in their home longer. And unfortunately that has played out particularly in the NDIS realm where it's not an emergency response system. So it's really important that we get in the preventative model and put in those supports with the expectations of how a person might deteriorate. So allied health can play a really good role in monitoring a person's daily health just through their own practice as well. Equally, it's important to involve them in your care plan. So things like medication changes, or even things like you're wanting to do blood tests or any other health interventions, which again, for some people, they might not be able to tolerate the standard practice. So we may need to look at alternate methods, and that's where we have behaviour support specialists who can actually play a great role in behaviour management strategies, as well as, for example, with occupational therapists, looking at sensory activities that might help to stimulate an individual in such a way that can distract them from having their healthcare poured in. So you can actually work together to achieve very simple healthcare goals. And it's really important, as I said, to involve and understand the role that allied health plays in supporting people with behaviours of concern. It very much is a holistic picture in that area. When people's behaviours escalate, yes, it can be underlying physical, but it can also be environmental or support needs that have changed. And that influence is really something that isn't always the easiest to pick up, but sometimes when you work together as a team, you can sometimes find those things when you least expect it. Next slide. Thank you. So I popped up the details for the Centre for Developmental Disability Health. Whilst we don't necessarily have allied health as part of our core staffing, we do obviously, as I say, embrace very much a holistic assessment and can assist and support in also navigating the systems with our nursing team to find other supports in the area. That's not to take away the role of support coordinators for NDIS participants, but obviously not everyone with a disability necessarily uses NDIS. So we're here to help. I've popped up our phone number and our email, and also you can visit our website. It does have a referral form on there that you don't necessarily have to complete if you don't know all the answers, but we do need someone who knows the person really well to complete that referral form so that we can get the best history. Thank you so much.
Thank you, Rhys. I really appreciate your input and your reflections on allied health and integration of adult health. And making this work well is challenging, and maybe we can talk further about that in the question and some of the ideal models or ways of making it work. So thank you. I'd like to now invite Andrew Pridding, who's from a nurse practitioner at the Victorian Dual Disability Service, or the VDDS. Hi, Andrew. Who's going to talk about health and intellectual disability. Thank you, Andrew.
Thank you. So I'm going to discuss mental health and intellectual disability. So our service is If we could have the first slide, please. There we go. So our service is based at St Vincent's Hospital, Melbourne. We're a statewide mental health service for people with neurodevelopmental disability. So that really refers to intellectual disability and autism spectrum disorder. We will see people with ADHD who have comorbid intellectual disability and autism, but we don't see people with ADHD on its own. We provide telephone advice to everyone. If we could go back to the previous slide, that would be. But predominantly our service provides assessment, consultation and education to public mental health services in Victoria. And the aim is to support mainstream mental health services when they are engaged with someone who's got a developmental disability. And the idea is to enhance the local mental health services response to be able to appropriately provide assessment and intervention. We also provide a rather more limited input for people registered with the NDIS who have either intellectual disability or autism. That's currently under review. It's previously funded via DHS and has recently been changed to include people who are registered with NDIS. Under that project, we do, under very, very exceptional circumstances, also take on people for time-limited specific treatment, usually in shared care with their GP. But because of our very limited resources, that is only under circumstances where the person's unable to access mainstream services. As I said, we're quite a small service. There are 3 part-time psychiatrists, and the nurse practitioner at the service. We do have a psychologist position that's vacant, and we have a registrar. Further information is on our website, and our referral process we've tried to make as easy as possible. Just ring us on that number and we'll try and discuss the issues and take the referral over the phone. If we go to the next slide. So intellectual disabilities defined as a developmental disorder under DSM-5, and it consists of significant impairment in cognitive functioning, significant impairment in adaptive behavior in at least 2 areas, and occurring prior to the age of 18, so during the developmental period. Also included under developmental disorders are communication disorders, autism spectrum disorder, ADHD, and specific learning disorders. And I think this is an important thing to consider, because having one developmental disorder makes you significantly more likely to have another developmental disorder. And then with each developmental disorder, that increases your risk of psychopathology. So you get an increased risk of mental health problems if you have an intellectual disability. If you also have an autism spectrum disorder or ADHD, that increases the risk even further. And if we could have the next slide. So comorbidity is common between developmental disorders. ADHD 3 to 4 times more common, and autism is about 14%. So that's about 14 times that found in the general population. Unfortunately, ADHD and ASD are frequently misdiagnosed or inappropriately managed. So our service, we see people from age 16 up, similar to the CDDH. But we still have referrals for people in their 30s, 40s and 50s asking for autism assessments or clarification of whether someone has ADHD or not. And in some cases, the features of those disorders are very clear and should have been picked up during childhood, but have been frequently missed or misattributed to other problems. If we could have the next slide, please. So just a brief history of mental health and intellectual disability. It has not been that long ago when people with an intellectual disability were thought of as not being able to experience other mental health problems. They weren't considered to have sufficient cognitive capacity to experience common mental illnesses. But despite that, they were subjected to the full range of treatments that were received by people with mental illness. But in recent decades, it's been accepted that they experienced the full range of mental disorders found in the general population. And that there is now a general consensus they're at significantly greater risk of experiencing those mental health problems. So rates of psychosis, for example, are around 3 times more common than found in the general population. There are high risks of affective and anxiety disorders, significantly increased risk of personality disorders, and that's being an increasing area of increasingly problematic area, because those people present with very complex, enduring problems and have great difficulty accessing services of any type. An increased risk of behavior disorders. So in addition to that, there are very high rates of often off-label psychotropic prescribing, attempting to address some of the disturbed behaviors that are commonly encountered. And what we find in a lot of our assessments is that medication often has very little or no relationship with diagnosis. So there's often this approach of prescribing to try and address behaviors with no consideration about where that medication fits with a diagnosis, if there is even a diagnosis being made. And further complicating that and proving to be a major issue with the NDIS is the insistence on reducing some medication has led to quite severe problems with increased behavior disturbance. And the studies on withdrawal of psychotropic medication are not really that convincing. There's not good evidence about what does and doesn't happen to people when they withdraw their medication that they've often been on for long periods of time. Added on to that, difficulty accessing appropriate psychological therapy. So there's a whole range of difficulties encountered by this population. If we could move on to the next slide. So the increased vulnerability to mental disorders can be attributed to a variety of biological, psychological, and social risk factors. So those are exactly the same as encountered by people without a disability, but there are a number of additional difficulties, such as genetic problems with some phenotype, behavioral and psychiatric phenotypes, issues around unidentified or inappropriately treated physical health problems, difficulties with reporting, communicating pain, and the whole range of psychological and social issues experienced by people just by the mere fact that they have a disability. If we could go on to the next slide. So that with establishing that there are a significantly increased risk and that these are some major problems, it should therefore be you would therefore think that, well, there must be a lot of people with intellectual disability receiving mental health services. But that's not the case. People tend to present more frequently, but have greater difficulty accessing services. And that's because there are significant problems identifying mental health problems in this group. So as I previously mentioned, there are high rates of unidentified or inadequately treated medical problems, difficulties working out if someone's behavior has changed because of a health issue or whether it's a mental health issue, problems that people can't easily identify when they have a mental health problem, then they can't report or communicate in a way to get them help effectively. Presentation can often be atypical, meaning that mental health issues aren't identified, or people, for example, with depression may not be causing a disturbance, so don't get identified as needing further assistance. And you generally tend to get referred for greater assistance if you're causing a disturbance to your carers or to the general community. So if you have depression and you're not interacting, you become withdrawn, you're less likely to get referred for assistance than if you're causing severe behavioral disruption. There are issues with communication. both receptive and expressive communication, and an increased reliance on informants, most of whom won't have any formal training or experience in mental health. So the language they're using to seek help from mental health services don't match what the mental health clinicians are looking for. So there's this mismatch in communication. Then there are classification difficulties, and people may not be able to ever meet the DSM criteria for particular disorders. And I'm thinking particularly around things like borderline personality disorder, where how would someone with an intellectual disability and communication issues communicate a sense of abandonment or feelings of emptiness when they don't have the capacity to express or articulate those concepts? Everything may take longer, they need more time, and the complexity is greater. And there are issues of overshadowing whereby everything's attributed to the intellectual disability, or that term that you hear time and time again. I took my son to the emergency department. They were seen by the mental health team. They were told it's behavioural and to go and seek supports from the NDIS. And that sort of tendency to attribute everything in terms of the intellectual disability and learned behaviour, rather than to look to see whether there is anything else going on. And if we could have the next slide. So in terms of management, complexity is the norm. So you have to work out, well, does this person have a mental illness? What are the implications of the intellectual disability, which is by its very nature very variable between individuals? And then how do you address mental health issues in these individuals? And it's fairly simple, because indications for treatment are the same as for everyone else. So indications for treatment for depression and psychosis are the same as in people without intellectual disability. The difficulty is they have greater problems accessing those services and those treatments. And access to services depends on diagnosis. There are also issues around the available supports, and specialist services are very few and far between, under-resourced and quite fragmented. And there are additional considerations and modifications that need to be made, which are often quite resource intensive and take some thought and time to work out. And then on top of that, there are unpredictable responses, and people tend to be prone to side effects that they often can't report. And if we go into the next slide, so access to mental health services, I've mentioned this before. The current philosophy, people should access the same services as everyone else. It's a good idea, it's a good concept, but we know from decades of trying this approach that people struggle to access the same services as everyone else. They need additional support to access those services. People are more likely to present to services, but less likely to get the response they need. And there are a whole host of major barriers, not least stigma and exclusion, people being intellectual disabilities not formally recognised in the majority of policies and legislations throughout the country. So pathways through services are lacking. There's not clearly identified training and education packages. There's almost an absence of intellectual disability, mental health content in undergraduate courses, and very few postgraduate education opportunities. There's limited practical support to access services, and there's a very, very limited number of private practitioners who are able and willing to see people with dual disability. And if we could go to I think this is the final slide. So in terms of what's available in Victoria, so there's the VDDS, which I've talked about, the CDDH, which has already been addressed by Rhys. So there are several other services. There's the Mental Health Intellectual Disability Initiatives, one based for adults in Dandenong, the other for youth based at the Alfred. Those were rolled out fairly recently and have been given ongoing funding. I'm not sure whether they'll be expanded to cover the rest of the state. They provide a treatment service within the area mental health services, but they're restricted to those catchments. There's also 2 transition support units based on a park model, one at the Austin Hospital and one based in Narre Warren. They unfortunately lack the capacity to manage significant behaviour disturbance. which is unfortunate because there's a desperate need for specialist inpatient services. And there's also specialist disability forensic and assessment and treatment services, but their resources are also very limited, and they can be quite difficult to access because of the significantly increased demand. And I think that brings me to the end of my talk. So the conclusion, yeah, I won't read this out. It's on the slide. I think to address the problems I've identified, interagency collaboration is vital, and I think GPs play a major role in that.
Thank you, Andrew, and yeah, indeed they do.
I'll put some resources in at the end. So there's the guide, which I think everyone should be aware of, but is not largely known. And there's also therapeutic guidelines, which has a developmental disability module.
I have one next to me. Thank you, Andrew. That's wonderful. Thank you. We'll hopefully come back and have some further questions on this incredible complex area of mental health and intellectual disability. Now I'd like to invite Dr. Robert Ward, who's talking about the importance of building education, GP education around intellectual disability, and briefly introduced reasonable adjustments.
Thanks, Nick. Hope you can hear me because my webcam's not working.
Okay.
Which is good, but you've got my slides, which is nice. You can watch them.
Your voice.
Thanks. Yeah. I'm Rob Ward. I'm a GP. I've been a GP for 24 years, and I also have a son with intellectual disability. So probably I get a fair few patients with intellectual disability because they sort of become attracted to me. Next slide, please. I've been asked to talk about sort of general practice and our training in intellectual disability, and it's really looking at the roadmap Nick was talking about, where they actually did a quote from the Disability Royal Commission that said the health professionals lack the knowledge, skills and appropriate attitudes required to address the health needs of people with a disability, which is a little bit disappointing since that's my general practice. That sort of should be business 101 and our core business to do that. And in that they say that many health professionals have minimal training. And when I talk to my medical students who are final year students, and I know it's been COVID over the last few years, but they said they've had no training whatsoever. So that they're going to graduate with no formal training. Next slide, please. I thought about sort of how do GPs learn about this sort of stuff, and often it's because we model the behaviour of the colleagues that come before us. We see our senior colleagues, we read their letters, we look at the staff, we even look at how our senior staff in our practices interact with our patients with intellectual disability. So we model a lot of our behaviours and attitudes and how we look at people with intellectual disability from others. And I suppose subsequently as GPs, other people will model their attitudes on us. So I think it's really important that we become the best that we can in looking after our patients with intellectual disability and interacting with them appropriately, and probably becoming up to date and learning the skills that we should do, because our attitudes will get modelled by those people who are more junior to us, by carers who come in with their patients, and so we want to have a good attitude and a good way to model forward. Next slide, please. General practice, we mustn't forget, is a specialty, and we should be really good at listening and communicating. We should be good at coordinating care. We should be good with chronic care and preventative health, and we should be good with appropriate and respectful care for all our patients, because all our patients are different. It is our core business. It's general practice 101, and we should probably, as a group of professionals, accept that as our specialty and embrace it and show that we can do it really well. I think if you're a professional athlete, you still get some coaching, and you still want to educate yourself more and more on your specialty, and I think that's what general practice should be doing moving forward. Next slide, please. So I thought about what I wanted to learn a little bit more about in this journey. I wanted to learn more about the communication, appropriate communication with patients. Often we sort of refer to carers, or we are talking to others, and we sort of forget the patient, especially with an intellectual disability. So I think it's really important for us to refocus on communicating with our patient. It's what we do with everyone else, and it should be no different from a patient with intellectual disability. We should make those adjustments that we need to make sure that we learn what the patient is wanting to tell us, and not necessarily what the carer or what the parent or what anyone else, but to actually spend some time and learn some skills where we can actually communicate with our patient. And in the same way as giving information to the patient, to give it in a way that they understand and not just refer to their carers. I'd like to learn a little bit more about the other people who are involved with my patient's care. Sometimes we can make assumptions that people that come with the patient with an intellectual disability have a lot of medical knowledge. You know, often if they're a disability support worker or a residential support worker, we make assumptions that, you know, they're like the nurses we trained with at the hospital, or that they have medical knowledge, and often they don't. And the examples I would like to think about is like when we're doing epilepsy support plans or medication lists, and we just assume that the person who's supporting our patient knows how to manage epilepsy. You know, we sort of sign off on these forms, whereas maybe we should take a step back and think about it more carefully and be more appropriate with our communication with regard to medication and care of our patients. I'd like to understand the system a little bit more. I mean, the NDIS is a bit of a mystery to me, even though my son's involved with the NDIS and I see a lot of people applying for it. You know, it's still a bit of a mystery. I'd like to know the diagnostic pathways, how my patient's getting diagnosed and who's involved in that. You know, it'd be nice to know more a bit about the Centrelink, you know, administration and guardianships, just so I can get my head around some of the expectations, because there's a bit of a changing environment over the last few years, where there are restrictive practices, there's restrictions to prescribing, as Andrew mentioned, the psychotropics. I think general practice, that would be an important thing to know. There's the NDS Quality and Safety Commission. I want to know where the other people who are helping look after my patients, what their restrictions are, and make sure I sort of fulfill the same or on the same page as them. Next slide, please. The other important thing is the MBS item numbers, particularly the care plans. I think it's important that we educate ourselves a little bit and sort of pre-plan these. And also it'd be really nice if we're doing care plans to do them in a way that's meaningful for our patients. Yeah, maybe in a way that they can understand them and not just printing off some random pro forma thing that gets them to see the podiatrist, but actually use the item numbers and communicate that in a way, even if it's in a really simple language, to help our patients. Preventative healthcare is really important. Yeah, and annual health checks. I don't know if many GPs use them, but the item 701s to 707s, they pay well. They're designed to pick up lots of health issues, particularly the CHAP tool, which is often presented to us by a carer. But I think we should embrace those things and actually plan for them a little bit. Next slide, please, because I just want to talk about reasonable adjustments. I hadn't heard of this term until I became involved in the SPIDER project. And I suppose a lot of the things GPs would do naturally, but sometimes you have to pre-plan a few things. So reasonable adjustments are those things that we do to support a person in an equitable way. And people with intellectual disability, it mainly involves our communication with them, maybe setting aside appointments at the start of the afternoon where they don't have to wait, setting up quiet times in the waiting room, making sure we maybe give them a call beforehand. And it also involves our staff as well, educating our staff to help with that. So next slide, please. So why do I need to better understand intellectual disability? It's probably so my patients have a better outcome. As Nick indicated before, the outcomes are not as good for with intellectual disabilities. So I sort of feel like I need to get on top. I want my patients to feel listened to. I need them to get the information they need to make informed choices. I need to better understand the difficulties that they face, and I also need to understand them more so I can better advocate for them. Next slide, please. And probably the practical things of GPs educating themselves or being involved in education, it can make our job easier sometimes. If you've got that little bit of knowledge, it can be the reminder about how to manage things, and we can actually work more efficient in general practice if you have a little bit of knowledge. I want to improve my confidence a little bit in treating my patients with intellectual disability. That leads to professional satisfaction. And the final one is to pre-prepare stuff. You can't do an annual health assessment if you haven't actually thought about it beforehand. If you actually haven't thought about the process and planned it out, you can't just randomly do it. So I think it's really important that we put these sort of things into our practice generally, so we can pre-prepare and do it properly. And final slide, I think. Really, in summary, so that people with intellectual disability have poorer outcomes. We've been identified as not having the knowledge and skills, and our training has been a bit ad hoc. So I think it's really important that we sort of be more involved and have a think about where intellectual disability fits within our practices and how we can move forward. And as Nick said, there's the national roadmap now, so that's going to be helpful. Someone's paying attention there, and it's important. So thank you.
Thank you, Robert. Appreciate it. And now we've got 9 minutes for any questions, and I think somebody's monitoring the questions. So can we?
Hi everyone. Yeah, it's Helene here. So I do have the questions here, but I don't actually have any questions from the audience as yet. So you've got some time if you'd like to type them in that questions box, and I can answer them for you.
I've got a question to start off with while they're doing that. Okay. So Rhys, in your practices in allied health, where have you seen examples of the integration, like concrete, where it's worked well? How, I think of working as a GP, this is can be really difficult for me because of time constraints and other things, but we don't communicate. And have you got some examples when it's worked really well in your experience?
Yeah, look, for one of my particular areas as an OT, wheelchair and seating prescription is one of my favourite areas and niches of practice. I've worked quite closely with people's GPs in the past, particularly around hips, and we look at getting x-rays. We've worked with GPs who have kindly been able to organise x-rays for my clients in the past so that I can see what their hips are like, because often if they're wheelchair users, depending on how long, if we go back to when they were children, they may have hip dysplasia. So when they're hoisted and flexed at the hip, they can often develop a lot of redness and arthritis, as you know, and inflammation. So it impacts their daily quality of life and pain, and that can then impact spasticity and other things depending on the person's diagnosis. So GPs have been fantastic when willing to work with me on trying to get some of those images done. The other area, of course, is around constipation. And so when, again, with wheelchair and seating, we look at how people can expand their diaphragm. So if they're constipated, and depending on how we seat them, they may actually be really quite impacted on how comfortably and how safely they can sit, depending on how badly the impacted bowels are. But equally, we see a huge impact on their daily function. So if we can't sit them upright as much as we need to, their eye engagement, their ability to use their arms is more restricted, etc. So we actually see a huge impact from just how we get their health sorted. So GPs are really great from that perspective. And obviously the other part, which Andrew touched on and talked about quite well, is around the behaviour management. And when we start to look at how we engage people in their daily activities, we really need to work with how their medications are sometimes managed. And whilst I never want to see medication to be long term, it sometimes is a short interim while we still work on other strategies to help support the person to engage in their daily life. So GPs play an integral part in how we monitor that together to look for improvement.
So what would be your approach if you're approaching a GP? What's your best way to engage? Because there's lots of allied health people on this, hopefully on this call as well. What's your key tips for them? And I'm going to come to you in a minute, Andrew, about that too. So, what, you know, if you were doing something, if you're rolling up and you want to talk to somebody like me or Robert, who, you know, maybe not easy to interact, how do you do it?
Yeah, I know. I know. I hear what you're saying, Nick. You're terrible to engage with. No, I think first and foremost, it's a conversation. It's getting the consent from the client to call their GP and have that conversation. The first point, not to write a report or a letter. That can follow later if need be. So they've got something for their own records and for your records, of course. But it's a conversation. It always starts as a conversation. And I've had great conversations and I've had some terrible conversations where you have GPs and specialists alike that just will not engage. They don't understand why an allied health clinician is asking them to do or guiding their own practice. But majoritively, most GPs really get on board, particularly when we rationalise why we're asking for it. I think that's the most important thing from an allied health perspective, is that allied health clinicians need to be very comfortable and confident as to what they're asking of the GP. They're very short for time. They're very rushed. You're often getting them between patients. And so you have to be very clear about what it is that you're asking from them from the get-go.
I mean, to me, it's kind of understanding in their shoes and understanding their dynamics that they've got going on as well, which is that time pressure often. I mean, it's the same thing around mental health. If somebody, Andrew, is reaching out, as a GP is reaching out to you guys, you know, my experience having practiced in Victoria is that I get very little support from mental health services. And, you know, what would you recommend? What are the key things? I don't know. What works well? What have you seen works well when you've been interacting with GPs or allied health professionals that have contacted you?
I think there's a varying levels of complexity, and I think that there are a number of people, a large number of people we're aware of who do quite well. So these are people who can articulate, who have carers who are very articulate and know how the system works, and they tend to get a very good response from the current services. Then there are people with more complex needs or who aren't able to articulate their problems, who may be behaviorally disturbed or whose carers may not be able to identify the issues that clearly, where they really struggle. And I think that the complexity and the fragmentation of the health and social care system is a huge barrier. And actually trying to explain that to someone, why can't we get this help when we need it now? But, oh no, you've got to have the correct label, and then you've got to go to the correct service, and you've got to know where that service is and what they provide. And they may not only be able to provide for a bit of what you need, and then you might have to go somewhere else for another bit. And you might have to wait an exceptionally long time for both those parts. And then when you get there, they'll often tell you, we can't help you, you need to go somewhere else. But so I think a lot of people actually working in the system don't understand how fragmented and chaotic it is.
Well, have we got any other questions before I pursue Robert on this issue?
No, I don't have any more questions, so I will just finish up with you, whatever you want to say, Nick, and I'll just before you start again, just thank everyone for coming and thank the presenters. It was a fantastic session, full of great information. I really enjoyed it. So thank you very much. And Nick, I'll hand over to you to finish off or ask any more questions. Okay. I don't have any others.
Okay. I don't know if you want to talk about that piece about what you found work, Robert, because as a GP reaching into the mental health systems or coordinating with you know, what's the best strategy? I know when I went to the UK and worked there, the social care team sat next to the mental health, to the healthcare team in the same room, and that worked really well. But we don't have that. I don't know if you've got any final words, Robert, as to what works well, tips for people in the community.
Look, I think it is really difficult, and I think it is very fragmented. All the care seems to be in silos, as Rhys mentioned, and it's really nice for general practice to get some information, to get some feedback from some of those professionals sometimes, because sometimes we feel way out of the loop. and we're on the periphery of something. So that communication, I think, is really important. But as you said,
Okay.
Nick, it is hard, and probably if you're not finding it hard, you're probably not doing it properly. If you're finding it easy, there's something wrong, because it is really hard. Yeah.
Okay. I don't like to
Yes.
leave it. Yeah. Okay. Well, I think we're out of time now, so I think I'd just like to thank you all for your wonderful presentations and your contribution to the Western Victoria PHN and the project here. And please, if people have got questions, they can contact us through the Western Victoria PHN. So thank you, and have a good day.
Thank you.
Thank you.